today's class is on Kala-azar, also called black fever. Basically, this disease, Kala-azar or Visceral Leishmaniasis, is caused by the organism, by the protozoa Leishmania donovani and other Leishmania species, and are transmitted by the bite of the sandfly, infected female sandfly Phlebotomus. Okay, so it's a protozoal disease that is caused by Leishmania donovani and other species of Leishmania. Now, in this disease, basically the organism, they attacks the immune system, causes abdominal visceral enlargement, particularly hepatosplenomegaly. The person present with prolonged fever, with anorexia, loss of weight, anemia and hepatosplenomegaly. Now, in certain patients, when the patient start to recover, there is discoloration of the skin rashes, and patients are called are caused to be suffering from post Kala-azar dermal leishmaniasis, and these patients are said to harbor the organism for a prolonged period and acts as a carrier. Now, about 90% of the cases of Kala-azar is reported in India, in Nepal, Bangladesh and in Brazil. The disease being also prevalent in the South America, Mediterranean basin, Central Asia and East Africa. Now, in India, majority of the cases are from West Bengal, Jharkhand, Bihar, Eastern UP, and the most burden of the disease is in Bihar. About 50% of the cases of Kala-azar worldwide is reported in Bihar. Now, this geographical location of the disease basically is important. Why? Because the species of the organism that is responsible for the Kala-azar is it differs as per different geographical location. And number two, the susceptibility to the drug also differs. Example, previously in the treatment of Kala-azar, sodium Stibogluconate was the drug of choice, but it has been seen that in India, Nepal and other adjoining areas, the disease is now resistant to sodium Stibogluconate, and we are preferring Amphotericin B. But again, the disease that is occurring in the South America or the East Africa, they are sensitive even now to the sodium Stibogluconate and is the drug of choice there. Now, Leishmaniasis is transmitted by the bite of the female sandfly Phlebotomus. Now, this basically organism Leishmania, they are present in the fly in the extracellularly in the flagellated form called promastigotes, but in the human being it is present in a flagellated form called amastigotes. They are present intracellularly within the macrophage. Now, Leishmania donovani causing visceral leishmaniasis is a potentially fatal condition. Other forms of leishmaniasis is also seen that affect mucocutaneous region, called mucocutaneous leishmaniasis, caused primarily by Leishmania brasiliensis, and dermal leishmaniasis that is caused by Leishmania tropica. Now, coming to diagnosis of the Kala-azar, as per the recommended guideline, the primary diagnostic test is the rapid diagnostic test, is the strip test RK39, by which we detect the antibody to the Leishmania donovani in the sample of blood. A patient having positive kit test with the clinical symptom are diagnostic of Kala-azar. Again, if the strip test is negative and there is clinically high suspicion of Kala-azar, we go for the alternative test, that is macrobiological parasitological confirmatory test, laboratory based parasitological confirmation, which is done by splenic aspirate primarily and also can be done by bone marrow aspirate, looking for the Leishmania donovani bodies. Now, coming to the drugs used for Leishmaniasis, that primarily we use 4 drugs: sodium stibogluconate, Amphotericin B, number 3 Miltefosine and Paromomycin. Now, Amphotericin B is which class of drug? Amphotericin B is which class of drug? It is an antifungal drug, but it is also used in the treatment of visceral leishmaniasis. Now, coming to the national programs, generally Kala-azar is a disease of the poorly socioeconomic poor condition found in the underdeveloped regions. Now, previously in the year 1990, India launched Kala-azar control program, which was upgraded to the elimination program in 2000. This is run under National Vector-Borne Control Program in India, and basically they are having the treatment guidelines which is followed all over India, and they are providing free treatment. And only confirmed cases, as per the guideline, only confirmed cases by rapid diagnostic test or splenic aspirate examination are to be treated with the drug, with anti-leishmania drug. Now, how we say the patient is cured? When the patient shows signs of improvement and there is no relapse within 6 months, they are said to be cured. Now, coming to the first drug, sodium stibogluconate. Basically, it's a water-soluble pentavalent antimony compound. It's a water-soluble pentavalent antimony compound. Now, although the antimonial compounds are toxic, but this drug in the pentavalent form is better tolerated. Now, it was initially the first line drug for the treatment of Kala-azar in India, but due to the extensive growth of resistance to the drug, now the first line drug is Amphotericin B, liposomal preparation of Amphotericin B. But still the drug is used as a first line therapy in other countries like East Africa, South America and others. Now, the mechanism of action, basically the thiol containing group of enzymes, is H group containing enzymes, they are inhibited by the antimony, and that is responsible for the inhibition of glycolytic and fatty acid oxidation pathway, and thus they interfere with the bioenergetics of the parasite. This is one mechanism. And the second mechanism is that recent evidence indicates that these organisms which are susceptible to the sodium stibogluconate, they have got a special reductase enzyme. And what does it cause? Basically, it reduces the pentavalent antimony to the toxic trivalent form, that is responsible for the efflux of the glutathione and other reduced thiols from the parasite, and thus they become susceptible to the oxidative damage. Now, how the resistance to the sodium stibogluconate is developed? When the parasite has a reduced capacity to convert the drug into the toxic trivalent form, number one, or by the alteration in the thiol mechanism. Now, these basically sodium stibogluconate, it is given parenterally intramuscularly, from which it is absorbed from that site and excreted unchanged in urine within 6 to 12 hours. But the important part is a small fraction of the drug is stored in macrophage and repeated doses hence become cumulative. Accumulation of sodium stibogluconate within the macrophage basically account for its prolonged inhibitory action on the leishmania. Now, although antimonials are toxic, they are better tolerated as pentavalent compounds, particularly SSG. Nausea, vomiting are the common side effects, including metallic taste, cough, pain, abdomen, stiffness of the muscles at the injection site, and sterile abscess can also be seen. Mental symptom can appear. Pancreatitis, hepatic and renal impairment, myelosuppression can be seen but are not severe enough. QT prolongation can lead to arrhythmias. Few cases of shock and death has been seen. Now, nevertheless, it is lesser toxic than Amphotericin B, used alone or in combination with Paromomycin, and is still the first line drug in East Africa, Central Asia and South America. Coming to the next drug, Amphotericin B. Amphotericin B is an antifungal antibiotic. They are present in two formulations. Number one is conventional, old, lesser expensive Amphotericin desoxycholate, and number two is the newer, more expensive liposomal Amphotericin B. Now, like fungi, leishmania, basically how they are acting on the fungus, they bind to the ergosterol, which is present in high concentration in the fungi. Similarly, this leishmania, they contain high amount of ergosterol, and this Amphotericin B bind to this ergosterol. They have got high affinity for ergosterol and thus act by binding to it. Presently, Amphotericin B is the drug with highest cure rate in Kala-azar, effective even in resistant cases to the SSG, sodium stibogluconate. Up to 99% of the clinical and parasitological cure has been reported from India in SSG resistant case and is treated as a reference drug while comparing the efficacy with other drugs. However, higher toxicity, prolonged hospitalization, monitoring and repeated slow IV infusion limit its application. Now, although previously SSG was the first line drug, but today particularly single dose liposomal Amphotericin B is the first line drug in the treatment of Kala-azar in India under the Kala-azar control program. Because Miltefosine is teratogenic, Amphotericin B is also the first line drug in pregnant mother and breastfeeding mothers. Liposomal Amphotericin B has got the advantage that it delivers the drug directly into the reticuloendothelial cells, including the liver and spleen, where the amastigote form of the organism reside. As such, even a single dose treatment with the liposomal preparation of Amphotericin B has been tried, reporting 90% cure rate at 5 mg per kg, 98% at 10 mg per kg. Amphotericin B is also useful in the mucocutaneous leishmaniasis. Now coming to the Miltefosine. Miltefosine is the first orally acting approved treatment for Kala-azar. It was initially tested in India in 1980s but was approved only in 2002 as the first orally active drug for Kala-azar. Now, due to the spread of SSG resistance in Bihar and neighboring areas, it is now the alternative treatment, alternative second line treatment in the treatment of visceral leishmaniasis in India. A 4-week course of Miltefosine has achieved 95% cure rate in India and 90% in Ethiopia. Cutaneous leishmaniasis also respond to the oral miltefosine. It is available in India only through NVBDCP. The mechanism of action. Although mechanism is not clearly understood how it acts, but possible it interferes with the lipid metabolism of the parasite or prevent the synthesis of some cell surface important anchor proteins or alter the signal transduction. Now, resistance possibly due to the mutation limiting transport of the drug into the parasite cell. Now, generally this drug is used in combination therapy to avoid the development of resistance. Combination therapy with Paromomycin or Amphotericin B. This drug shows biphasic elimination. When the drug is started, the early phase in early phase half-life is 7 days, but the terminal half-life becomes around 28 days or 4 weeks. Anorexia, vomiting, diarrhea are some of the commonest side effects, but generally decreases with the continued use of the drug. Skin allergy, transaminitis are reported but are not severe enough and stops with stopping the drug. Reversible kidney dysfunction can be seen. Now, it is contraindicated in pregnant mother and it is ensured when the therapy is started, the female patient is not pregnant and it should be the pregnancy should not be allowed up till 3 months of stopping the treatment. Coming to Paromomycin, it's an aminoglycoside antibiotic. Can you name some aminoglycoside antibiotic? Can you name some aminoglycoside antibiotic? Huh? Sorry? Amikacin, gentamicin and others. So, this is an aminoglycoside antibiotic. It is given parenterally by intramuscular route. It is approved in India for use in VL by the IM route. The drug can also be used orally for the treatment of protozoal disease, but it's not, the oral Paromomycin is not available in India. Over the past decade, Paromomycin has been widely tried in India and Africa for the treatment of Kala-azar and is effective in SSG, sodium Stibogluconate resistant cases. WHO recommends 21-day Paromomycin treatment as an alternative to Miltefosine. It has been proven to be effective, less expensive and easier to use alternative in Kala-azar. And topical Paromomycin is also useful in PKDL, post Kala-azar dermal leishmaniasis. Coming to the treatment protocol for Kala-azar, as per the national guideline, number 1, the first line therapy for patients of Kala-azar is liposomal preparation of the Amphotericin B, single dose 10 mg per kg, infused over 2 to 4 hours in 5% dextrose. Alternative or combination therapies are number 1, multiple dose of liposomal Amphotericin B, 7 days oral Miltefosine can be combined with either single dose liposomal Amphotericin B or 10 days Paromomycin intramuscularly. And again Amphotericin B desoxycholate 1 mg per kg daily or alternate day for 15 to 20 injections. Coming to the treatment of the post Kala-azar dermal leishmaniasis, these patients act as a reservoir of the parasite and require rigorous treatment to maintain elimination progress. The treatment is Miltefosine, oral Miltefosine taken daily for 12 weeks. Alternatively, Paromomycin or Amphotericin B can be used. Coming to the HIV and Kala-azar co-infection or Leishmania co-infection. Now, co-infection of HIV and Leishmania are dangerous. Why? Because a person of having visceral leishmaniasis. Now, in HIV positive, it is taken granted that this patient is suffering from AIDS, and irrespective of the CD4 count, the antiretroviral treatment has to be started. Again, basically HIV positive subjects are more likely to develop visceral leishmaniasis and harbor high load of the protozoa. Again, co-infected patients have a poorer response to the antiretroviral therapy and the anti-leishmania drugs, and the mortality is high. Patients with compromised immunity such as HIV-VL co-infection generally require higher cumulative dose of liposomal amphotericin B over multiple weeks to prevent relapse, followed by secondary prophylaxis. Now, these were all about the Kala-azar. Now, coming to Giardiasis, basically this the causative organism is Giardia lamblia. It is a flagellated protozoa that infects children and adults, transmitted by fecal-oral route. They basically, in the intestine, they act as a commensal. In certain individual, they invade the mucosa, causing acute watery diarrhea. If the disease is not treated, it can turn into the chronic diarrhea, although it does not cause dysentery. There is no blood in the stool and there is no mucus. Many drugs that are used in MBBS are useful in this basically Giardiasis. Now, what are the drugs that can be used in MBBS? Anyone? Drug in MBBS? Commonest drug that we use is Nitroimidazole, like metronidazole, tinidazole. So, here also the first line therapy is Nitroimidazole, metronidazole 400 mg TDS for 5 to 7 days or 2 gram daily for 3 days, or tinidazole 0.6 gram daily for 7 days or 2 gram single dose. These may be considered as a drug of choice and can cure 90% of the subjects. In 10% of the subjects, repeat courses can be required or alternative therapy may be needed. Now, coming to the second group of drug, nitazoxanide. Nitazoxanide basically is a prodrug that is converted to tizoxanide. Now, it is a PFOR enzyme inhibitor that is responsible, that act in the glycolytic pathway, and thus they are useful in the treatment of diarrhea and dysentery caused by Cryptosporidium parvum, Giardia lamblia, Entamoeba histolytica. Dose 500 mg twice daily for 3 days, efficacy 80% as comparable as to the nitroimidazole group of drugs. Tolerability is also good. Quinidochlor, basically 250 mg TDS for 7 days, less effective alternative. Coming to Paromomycin, unlike in the Kala-azar where it is used intramuscularly, the drug is used orally here. Orally 500 mg TDS for 5 to 7 days, less metronidazole but safer, free of systemic side effects and can be used during pregnancy, although oral formulation is not available in India. Furazolidone basically is a nitrofuran compound active against many gram-negative bacilli including Salmonella, Shigella, Giardia and Trichomonas. 100 mg TDS for 5 to 7 days, not the first line therapy in any of the case. And furazolidone is partially excreted from urine and the urine turns orange. Side effects are mild and infrequent, nausea, headache, dizziness. Coming to the Trichomoniasis caused by Trichomonas vaginalis, is a common sexually transmitted disease in basically sexually active females. Now, it's another microaerophilic flagellated protozoan which causes vulvovaginitis. It's a common sexually transmitted disease affecting 10% of sexually active women. Now, several drugs basically are partly effective in this case by vaginal application, and the recurrent courses of therapy or the repeat courses can be needed. Drug used orally here for the treatment of Trichomonas vaginalis, drug can be used orally and via intravaginal application. Drug of choice again here is nitroimidazole, like metronidazole, tinidazole, secnidazole. Now they are growing resistant to the nitroimidazole therapy, nitroimidazole resistant Trichomonas vaginalis, where the drug can be given at higher dose or can be combined with intravaginal drug application. Additional intravaginal treatment is required only in refractory cases. Now, in certain recurrent cases, the male partner basically harbors the infection in the seminal vesicle, although they are not affected by it. In those cases, basically both the partner should be treated concurrently. Now, drugs that are used intravaginally, they include diiodohydroxyquine 200 milligram inserted intravaginally for 1 to 2 weeks, quinidochlor 200 milligram intravaginally for 1 to 3 weeks, and povidone iodine 400 milligram intravaginally for 2 weeks.